Okay, let's talk high triglycerides, hypertriglyceridemia. It's encompassed in the term dyslipidemia, and you're wondering why the heck are we discussing this in the endocrine course? It's a great question. So, endocrine conditions such as diabetes, hypothyroidism, they can lead to changes in lipid levels. Our hormones control every pathway for our metabolism, for fats and proteins, how they're transported to support metabolism. And our hormones that are involved in this process are estrogen, testosterone, insulin, cortisol. See the separate talk on Addison's disease, okay? Growth hormones and glucagon, okay? So while hypertriglyceridemia, we'll just call it HTG, and HTG itself is not considered an endocrine disorder. Endocrine disorders are a major cause and condition associated with, or maybe even directly contribute to the development of hypertriglyceridemia. And this is really poorly controlled in cases of diabetes and hypothyroidism, and a major contributor to cardiovascular disease. Okay, so when we talk about triglycerides, these aren't entirely bad things, okay? Lipids and fats, they're either absorbed from our food, so triglycerides are super important for dietary energy, and we store these in our adipocytes and muscle cells. We get these from animal fats and vegetable oils, so don't worry, vegetarians, you're getting your adequate triglycerides. And although when these are too high, like most good things, right, we need sugar, but we don't want to eat too much. They can contribute to disease. So both triglycerides and cholesterol can contribute to disease, but they're also so physiologically important that they're actually made in our liver. When we talk about hypertriglyceridemia, HTG, we're talking about excess fasting concentrations of triglycerides, TGs. This is a form of dyslipidemia. There's two categories. There's moderate, which goes up to 499, and then there's severe, which is over 500. And those are usually characterized by an excess of our VLDL cholesterol and chylomicrons. It's a major risk factor for acute pancreatitis, especially over levels of 500. And if you have triglycerides over 1,000, you're almost guaranteed to get pancreatitis, okay? It's actually the third leading cause of pancreatitis. If you've never seen someone with this in the hospital, they are miserable. It's hard to watch, okay? So what's interesting is it's unclear whether hypertriglyceridemia causes atherosclerosis or if it's just a marker for cardiovascular disease. There's just not an established causal relationship. However, the reduction of hypertriglyceridemia is proven to reduce cardiovascular risks. So in certain patients, we individualize our care, and we really should consider hypertriglyceridemia to be an independent marker for risk factors in some patients for cardiovascular disease. In terms of epidemiology and prevalence, males are at greater risk than females, and Hispanics and whites greater than black populations. And the U.S. has a massive population with levels. That's over a third of our U.S. population has a triglyceride level over 150 milligrams per deciliter. Ouch. All right. We're going to find this probably worse in the adults age 50 to 70, and I kind of attribute this. Maybe that's the age where we start having alterations in hormones too, right? And there are a small population of genetic syndromes that have this. It's a familial inheritance, and you can be as healthy as you want, but you can't pick your parents, and unfortunately, they struggle with their triglycerides. So the primary familial inherited causes like I said, they're super rare, and they can be autosomal dominant. There's a few acquired sporadic cases, but this is a majority of a secondary disease. So again, this is why it's associated with endocrine diseases, metabolic syndrome, etc. So lifestyle contributions like obesity, inactivity, tobacco use, high alcohol use, and a high carb diet. So if most of your calorie intake is greater than 60% carbs, you're going to have high triglycerides. Medical conditions associated, again, diabetes, metabolic syndrome, hypothyroidism, chronic kidney disease, liver disease, and autoimmune disorders in pregnancy. There are some medications that can also contribute, which include the atypical antipsychotics. Many times people also gain weight when they take these. The non-selective beta blockers, bile acid sequestrants, those poor people that have issues with their gallbladders. Chronic glucocorticoid use can cause hypertriglyceridemia, oral estrogen use, thiazide diuretics, interferon, some retinoids, and more. So always have to look at those side effects. Always look at that medication profile that the patient's taking as another reason if you have a finding of hypertriglyceridemia in an otherwise kind of healthy patient, right? Again, genetic forms are very rare. So risk factors, again, genetic susceptibility, rare, but it can happen. All those things that cause metabolic syndrome, including obesity, sedentary lifestyles, diabetes, alcohol, predisposed other endocrine disorders. And prevention is always preferable to cure. So if you can maintain a healthy body weight, moderate that dietary fat, limit those refined carbohydrates, have regular aerobic exercise, and avoid excess alcohol, it's going to help decrease your risk of developing this. In terms of diagnosis, we want to get a good history. As always, we can almost make a diagnosis given the history. So we want to look at the cardiac risk factors and family histories of coronary artery disease, and then our good old-fashioned physical exam, okay? So the signs are chylomicronemia syndrome. So this is memory loss, headache, vertigo, shortness of breath. They've got these paresthesias. This can be very vague and hard to pick up on. Somebody that's coming in with acute nausea, vomiting, and they've got that mid-epigastric tenderness, probably spot on with pancreatitis, okay? Obesity, if their BMI is over 25, again, I don't really believe in BMI. I think truncal obesity and being generally overweight. Xanthomas, so these are like an eruptive yellowish plaque. You can see them around the eyes. You can actually see them in the fundoscopic exam, and it's interesting that they also kind of accumulate over joints. All right. Again, if they have mid-epigastric pain, you push on it, ouch, they come off the table. High suspicion for pancreatitis. They will have hepatomegaly because they'll have NASH syndrome. Okay. And it must be a typo that I put lip on there. Sorry about that. When we talk about diagnosis, let's look at labs. We're going to have, if you have somebody with super hypertriglyceridemia, especially over 1,000, we'll pick up their tube and it will literally look like this. Okay. It's turbid, it's milky. Okay. We want to get a fasting or a non-fasting lipid panel. So the USPSTF always recommends screening at age 40 up until 75, and then calculate their 10-year ASCVD score risk. And then depending on that, you can repeat the screening process every 5 years. The American Academy of Pediatrics actually recommends screening at 9 to 11 years, and then later at 17 to 21 years of age, because they found sufficient evidence of increasing likelihood that children will have elevated triglycerides because we're also having higher rate of obesity in children, right? So even if it's non-fasting, don't starve your patients if they're coming in at 3 o'clock. If they're high, confirm this with a fasting measurement. We need to evaluate for secondary causes. So think about obtaining an A1C or associated causes. Make sure we're screening for fasting glucose, rule out diabetes. We want to look at their kidneys. All right. Look at endocrine causes. So pregnancy, even TSH, hypothyroidism. Again, if your physical exam is suggesting pancreatitis, go ahead and get that serum lipase. You can get an ultrasound of the pancreas. It's probably going to be your first line in someone with pregnancy, but oftentimes it's gassy and very difficult to identify. So a CT, even without contrast, is sufficient and very limited radiation dose compared to with contrast. In terms of atherosclerosis, because it's associated with, it's a cardiovascular risk factor, especially if you do your scoring system, make sure you're doing cardiac stress testing, doing that coronary CTA, maybe even a cath, etc. In terms of monitoring, once you start drug therapy, we're going to be monitoring not only their levels, but CKs, right? Because just like statins, treatment can cause rhabdomyolysis. In terms of treatment, okay, so our first line with most of our metabolic syndromes are going to be lifestyle change. Just by lifestyle alone, we can reduce our triglyceride levels by 50%. And dietary modification needs to be done. Again, over 30% of Americans are obese, and we need to work on our diets. So decrease that carb intake. That food pyramid from the 80s is gone, people. Okay, so we need to reduce our caloric intake of carbs, and that includes alcohol. Okay, moderate intensity physical activity. So get that person exercising, even if it's just moderate, walking daily. We can reduce their triglyceride level up to 30%. That's huge. Weight loss, just even 5 to 10% can reduce triglycerides by 20%. And if they're very high triglycerides, they really should be abstaining from alcohol, period, because they're going to be super high risk for pancreatitis. I just had a patient hospitalized, and she said that she stopped drinking a long time ago because she couldn't even have one drink. She had familial disease, unfortunately, and she couldn't have one drink of alcohol without getting acute pancreatitis, and it just was not worth it. We also want to prioritize our cardiovascular risk reduction, so lower our LDL, and then in our HDL, all of that, prioritize that over triglycerides, but this needs to be also intentionally done. We need to improve glycemic control if they're diabetic and control other cardiovascular risk factors, as always. Prevention. Always identify and correct any secondary causes if we can, underlying illness, i.e. hypothyroidism, Addison's disease, things like that, or remove the offending drugs. Again, if they're on an atypical antipsychotic, maybe you can try a typical. You might need to consult with their psychologist. And then in primary hypertriglyceridemia, if you're finding this, you need to screen other family members. Okay, let's talk about treatment. We've already tried our first line conservative treatment, and we can make great strides with lifestyle modification. Unfortunately, it's really hard to get people to adhere to that, but we can just keep coaching them, right? Fibrates are actually the most effective agents for reducing triglycerides, up to 50%, and they're used primarily to reduce the risk of pancreatitis in severe HTG, and they have been shown to decrease non-fatal MIs, but all in all, not all cause mortality. So generally speaking, statins are first line, especially in patients with triglycerides that are under 500. So we'll start a statin if their ASCVD score is greater than 7.5%. If the first, we want to primarily decrease that LDL so we can decrease that cardiovascular risk factor. So our goal, again, we're trying to knock out this cardiovascular risk management. It's been highly studied, okay? Associated with the LDL reduction, they can up to 30% reduce triglycerides. So rosuvastatin, super cheap, that can be done daily. Torvastatin, also super cheap, and start low and go slow in those elderly patients, okay? Adverse reactions are not uncommon. Patients will come in and complain of myopathy. I hear a lot, okay? Myalgias, sometimes they get used to it, sometimes they just cannot tolerate them. Rhabdo is real, so especially when combined with fibrates, we need to keep on the lookout for that. Do note that statins are contraindicated in pregnancy and breastfeeding. So again, fibrates, they're really good at reducing those triglycerides. And in patients with triglyceride levels over 500, this is really going to be the goal to reduce that risk of pancreatitis, and you're really going to have the greatest amount of triglyceride lowering power. Okay, but when you talk about studies, the magnitude of our clinical benefit is uncertain. So statin is generally recommended for the cardiovascular risk reduction part. Then the additional use of our fish oil, omega-3 fatty acids, and then cautious use of fibrates in addition can be used. These, again, adverse reactions can cause GI upset, hepatotoxicity. These people, if they're really, really high triglycerides, or they're having pancreatitis, they might already have hepatic steatosis, fatty liver. So cholelithiasis, they can also be at risk, again, for myalgias and rhabdo, especially when they're combined with a statin. And there is a interaction with warfarin, which interacts with a lot of medication. So we all should be aware of that. Okay, second line drug therapy. Again, our omega-3 fatty acids. There is a little bit of conflicting data here. Do note that it acts like aspirin. When I operate, people ooze and they ooze and they ooze. So it can act like aspirin, so it might cause them to bruise. It's generally held before surgeries, okay? They may lower cholesterol up to 50%. Not everyone really tolerates these due to GI side effects. They are preferred with high ASCVD risk scores. So Vasepta is one that's frequently used, and then there's some other fish oils. In terms of emergent management, this is going to be in the case of acute hypertriglyceridemic pancreatitis. And this is going to be most common when you see it in somebody with triglycerides over 1,000. I had a patient with it a couple weeks ago, and they came in with triglycerides over 3,000. Incredibly sick, in the ICU for a week. Okay. Our goal is to get it under 5,000. You can use apheresis, plasma exchange initially. It's very invasive. It's expensive. You can start with an insulin infusion, and that is going to take a few days, at least on average three or four. When you're doing an insulin infusion, whether or not they're diabetic, you have to give them D5, and then it's they have to be in the ICU because it's a constant up and down with their blood sugars. If they have pancreatitis, they're probably throwing up, they're not eating, so it doesn't matter if they're diabetic. They're at high risk for developing hypoglycemia. That's probably all you can take today. I hope this helped, and I have some great resources. Again, I love osmosis. I love Khan Academy for some of the basic pathophysiology. The mechanism of our entire cholesterol system and hormones is incredibly complex, and it's really fun to learn, but that is not the purpose of this lecture. 5-minute consult is a great database to use if you're a new provider. It helps you with a nice algorithm so you can kind of take that stepwise approach to management and care. I hope you have a great day.